Shyam, are you there?
Yes, sir, I'm here, sir.
Okay. So at 7 we will start, huh?
Yeah.
Now
We'll start, sir.
We have another 2 minutes. 1 minute.
Can I start, sir?
Just a minute. We will wait 1 more minute. We'll see how many. Only 13 now.
Yes, sir. So this is basically for the only postgraduates, sir.
Postgraduates as well as practitioners.
But how we are communicating to others, sir? Like
Through WhatsApp groups.
Okay.
Because very few people are checking regularly the emails also.
Yeah, emails nowadays not.
So easiest way and fastest way is the WhatsApp.
Okay. Mallareddy HOD asked me like we are not getting information how to get the.
No, it must be there in some group because because of sometimes they don't check, so that is the problem.
Okay.
So what I said to Surendra sir is I will share personally.
Okay.
If that is the case, I will share personally to them.
Okay.
Otherwise,
we can create one because even I never received anything when I am in.
So we have a separate PG teaching group also with all the HODs and all.
Okay.
But even we are sharing in that also most of the time.
Okay.
So we will add you if you are not in some group.
And this is the first time I received. Like so far, I never.
No. Are you not in this ISA Hyderabad? So many groups are there now.
Recently joined.
1, 2, 3, 4, 5, 6. So many groups are there.
Okay.
Hyderabad ISANs.
Yes, true.
So that is not a problem actually. So we will do the campaigning. We are doing campaigning vigorously actually.
Okay.
From this last webinar.
Okay, definitely.
So I think we will start now. So I will just give a brief introduction.
Yes, sir.
So, good evening, all. Welcome to ISA Telangana webinar series, which is now this is 10th webinar for this year. I would like to introduce Dr. Shyam Sundar, our new coordinator, very young and enthusiastic. He is additional professor at AIMS BB Nagar. I hope he will do very good webinars. So as I expected, he got 2 speakers for today, Dr. Ananya from ESI Medical College and Dr. Sandeep from AIMS BB Nagar itself. Very interesting topic today. Cardiothoracic anesthesia we started. Actually, we thought of doing system-wise. With all our coordinators expressed that opinion. So to start with today, this thoracic pre-anesthetic evaluation and other things. So now I hand over the webinar to Dr. Shyam Sundar. He will introduce the speakers and he will add some things as well as he will take up the questions and make the speakers answer. Thank you. Over to Shyam Sundar.
Yeah, thank you, sir. First of all, I welcome you all. Good evening. And before starting the topics, I would like to thank organizers like Veeresham sir and Ramakrishna Reddy sir for giving opportunity to us like AIMS BB Nagar. And I want to share that we recently has been sanctioned 4 PG seats each. Every 6 months, 2 seats will be there for postgraduates to join in our institute. Apart from this, we have SR posts also available. Please monitor, watch on our websites for updates. Regarding this today's topic, one lung ventilation, I have divided two parts. One is basically pre-anesthetic checkup. Second part, which will be dealt by Dr. Ananya. She has done fellowship in cardiac anesthesia. And the second part will be like how to manage one lung ventilation during the surgery. This part will be done by Dr. Sandeep, who is my student as well as junior colleague at AIMS. He has done DM from Chitra Institute of Medical Sciences. So with this brief introduction, I request Dr. Ananya to start the presentation.
Thank you so much, sir, Dr. Shyam Sundar, sir, for giving this kind introduction. I would at first like to thank ISA Telangana for including me in this PG teaching program, and for Dr. Shyam Sundar for giving me this nice topic. So without any further wait, I think we'll start with the physiology of one lung ventilation. So today I'll be discussing the pre-anesthetic evaluation of a patient who is coming for any lung resection or a pulmonary resection surgery, and how does the physiology change in such patients. Just a moment, sir. It's not moving.
Right click, Mark. You just put right click. Yeah.
So we'll be discussing this under the following outlines. That is first, respiratory physiology in the supine and the lateral decubitus position. What changes occurs in the physiology during one lung ventilation? A brief discussion regarding hypoxic pulmonary vasoconstriction, following which we'll look at the pre-anesthetic assessment of a patient undergoing lung resection surgery. So introducing the principle of one lung ventilation, what I think is one lung for the surgeon, that is the non-dependent lung, and one lung is for the anesthetist. So we are the perioperative physicians, and it is entirely under our control how we manage the ventilation as well as the perfusion, especially after the induction of anesthesia, one lung ventilation, and the opening of the chest, all of which come together and uncouple ventilation and perfusion matching. So looking at the respiratory physiology in the erect position versus the lateral decubitus position. So this is a diagram where it has been divided into 4 zones of the lung. So West initially gave us the 3 lung zones. So the zone of collapse, then the waterfall zone, and the distension. So here in the erect position, the alveolar pressures are the highest in the zone 1, whereas the pulmonary arterial pressure remains more than the alveolar and the venous pressure in the zone 3. So zone 3 gets more of the blood supply, whereas zone 1 gets more of the zone 1 gets the alveoli remain distended because of a negative intrapleural pressure. So when we change this into the lateral decubitus position, the vertical distance decreases. So the area of zone 1 does come down, because of which there is more ventilation and perfusion to the base of the lungs, and the remaining of the zone remains the same. So looking at this picture, like we can see, the perfusion, that is the blood flow to that of the lungs, as well as the ventilation, is more towards the base of the lungs. And as we go up or as we go towards the apex, both of them decrease. When they performed a scan of the in vivo of a patient breathing, it was also found that in addition to the gravitational blood flow distribution in the upright position, there was also a decrease in the ventilation and perfusion when we went from the center of the lungs towards that of the periphery. So what distribution takes place in the alveoli? So like we can see in this diagram, the ventilation is more, in regards to ventilation, the intrapleural pressure is more negative towards the apex of the lungs, whereas perfusion is again on the lower side towards the apex of the lungs. But as we move towards the base of the lungs, the intrapleural pressure becomes less negative, and moreover, because of gravity, the perfusion remains more in the base of the lungs. So because of this, here the alveoli are smaller in size, and they are more favorable for recruitment and distension. So when we combine all of these physiology together, we get the pressure volume relationships. So like we can see in this graph, the base of the lung is at a steeper or the more compliant portion of the pressure volume relationship, whereas the apex of the lung lies in the flatter portion of the pressure volume relationship. So this sorry, sir. So when we combine the blood flow, the ventilation all together, we get the ventilation perfusion matching. So this now varies in different areas of the lung. So ventilation perfusion ratio in the zone 1 stays high at the ratio of 3.4. In zone 2, it is 0.8. And in zone 3, it comes down to as low as 0.63. Now, when we come to the lateral decubitus position, now various parts have been, or the subsections have been described in the respiratory physiology. So here we'll be looking at the lateral decubitus position when a patient is awake and breathing spontaneously with a closed chest. Now, when such a patient undergoes anesthesia, what happens? And then what happens when we open the chest? So coming to the lateral decubitus position in a spontaneously breathing closed chest person. So this is what happens when we are sleeping. So what happens here is that there is not much of a change, but the dependent lung as usual gets more perfusion as well as ventilation. The perfusion being gravity dependent does not change. So because it decreases linearly from base to apex, and ventilation increases at the dependent lung. Now, why does ventilation increase? So this happens because our diaphragm being an irregular dome shape, it helps in effective pushing and therefore effective contraction of the dependent hemidiaphragm, because of which the ventilation takes place better in the dependent lung. Now, anesthesia. So when anesthesia comes in the picture, on the pulmonary function, it has got multiple roles. So induction of anesthesia decreases the functional residual capacity by almost 33%. The vital capacity comes down to 25%. And there's also a decrease in the pulmonary compliance. The tidal volume also shows a decrease of about 15 to 20%. So anesthesia, pulmonary function, and the lateral decubitus position. So when it comes together, we see that there's a reduction in the functional residual capacity in both the lungs. There's an increase in the ventilation in the non-dependent lung. Now, why does this increased ventilation occur? So once we induce anesthesia in a patient, there is positive pressure ventilation. So because of which in mechanical, it favors a non-dependent lung because it's in a more compliant stage. Instituting neuromuscular blockade causes diaphragmatic paralysis, which again allows the abdomen to push the dependent hemidiaphragm and impede further the ventilation of the dependent lung. And if you're positioning the patients using sandbags, this suboptimal positioning can also further restrict the movement. So when we look at the diagram and compare the ventilation perfusion of a patient who is awake and lying in lateral decubitus position, as we see in this picture, the non-dependent lung now moves to the steeper part of the pressure volume relationship, whereas the dependent lung now goes to the flatter portion of the pressure volume relationship. So like I said, the two reasons why there's an increased ventilation to the non-dependent lung. One is the cephallar displacement of the diaphragm and the mediastinal structures pressing on the dependent lung. Now, in an awake patient who is undergoing thoracoscopic procedure, let's say we are taking a biopsy in him, or we are doing some similar procedure under a peripheral nerve block, under the intercostal nerve blocks. So this simulates an open pneumothorax-like picture. Now, when this comes into question, there are two complications that can arise. So what happens when there's an open pneumothorax-like picture? We see there is a mediastinal shift. So because the pneumothorax occurs over here and there is entry, the negative intrapleural pressure is lost, because of which there's a downward shift of the non-dependent lung and it presses onto the dependent lung, especially during inspiration. So whenever the patient takes a deep breath, the non-dependent lung pushes, and this can cause a circulatory collapse or a shock-like situation. Now, next what happens is also we see is the paradoxical respiration, that is also called as the pendulum. In pendulum, there's a to and fro gas flow between the dependent as well as that of the non-dependent lung. So whenever the patient is trying to breathe, because the pneumothorax will increase and the gas will flow from the non-dependent lung to that of the dependent lung, and during expiration, it will flow back into that of the non-dependent lung because it is more compliant. Now, this represents wasted ventilation and again can cause a severe ventilation perfusion mismatch. If a patient is now anesthetized and he's in the lateral decubitus position and open chest, so this will have very little impact on perfusion, it being gravity dependent, but Because the upper lung is no longer restricted by the chest wall and free to expand, it can cause a further increase in the ventilation perfusion mismatch. So now what happens for a patient who has been paralyzed? So like I said, the various factors that come into play are the open chest in the non-dependent lung. So this causes the mediastinum to come down and press on the dependent lung. And here the suboptimal positioning of the lung. On top of the diaphragm is paralyzed, because of which the dependent lung, although it receives better perfusion, it remains underventilated and therefore causes a high degree of ventilation perfusion mismatch. When the same phenomenon is compared in a one lung ventilation setting, that is, we are stopping the ventilation to that of the non-dependent lung. So now the various other factors that come to play an important role are the amount of lung disease which is present in the dependent lung, the magnitude of hypoxic pulmonary vasoconstriction that can take place, and any surgical interference and the mode of ventilation being used. Moreover, once here, since hypoxic pulmonary vasoconstriction comes into place, it increases the shunt fraction, and we'll see what happens. So comparing the two lung versus the one lung ventilation, so in a normal setting, there is increased blood flow that is about 60% to that of the dependent lung and 40% to that of the non-dependent lung. When we go to that of a one lung ventilation setting, the normal blood flow to the lung or the perfusion to that of the dependent lung comes down to 77.5%. Now, why does this occur so? So at first, there's a normal physiological shunt of about 10%, which is equally shared between both the lungs. But when hypoxic pulmonary vasoconstriction takes place, it reduces the blood flow to that of the non-dependent lung by almost 50%. So this comes down to 22.5% in total, and the remaining perfusion comes to that of the dependent lung. So hypoxic pulmonary vasoconstriction is an autoregulatory mechanism which actually helps in decreasing the ventilation perfusion mismatch. Now, if we, like I said, so only one lung is in our hands, and that is the lung which we are trying to manipulate to the maximum extent so that we can achieve adequate arterial oxygenation and carbon dioxide elimination. Carbon dioxide elimination is not much affected because there's a linear relationship of the carbon dioxide graph. Whereas in arterial oxygenation, yes, there's a greater decrease in the PaO2 there's a greater decrease in the PaO2 when the patient undergoes one lung ventilation. So coming to a brief mention regarding hypoxic pulmonary vasoconstriction. Now this concept was first brought into picture by Euler and Liljestrand in 1946. It's an autoregulatory mechanism which tries to normalize the ventilation perfusion relationship, especially when there are hypoxic areas of the lungs being present. It requires at least 30 to 70% of the lung to be hypoxic, and there should be normoxic areas of the lung, so where it can divert the blood flow so that adequate oxygenation and ventilation can take place. Hypoxic pulmonary vasoconstriction has shown in various studies to increase the PaO2 to a much more safer level than what would have been expected if there was no hypoxic pulmonary vasoconstriction. So this model graph shows the effect of hypoxic pulmonary vasoconstriction as a function of the percentage of lung that is hypoxic. Now, what are the mechanism of actions of hypoxic pulmonary vasoconstriction? So the primary stimulus for this is the pulmonary alveolar oxygen tension, and this depends on the principal pathways of the endothelin 1, the nitric oxide, and the prostaglandin pathways. So these pathways play an important role in causing the pulmonary vascular smooth muscles to constrict in the hypoxic areas and to dilate in that of the normoxic areas so that this can take place. Now, various factors play an important role in manipulating or in managing the hypoxic pulmonary vasoconstriction. So direct inhibition can be seen by the use of volatile anesthetics. So it was much more pronounced when we were using halothane, very less seen with desflurane and isoflurane. Use of vasodilators, so because they will again remove the HPV component. If there is an increase in the pulmonary vascular resistance, like seen in volume overload, in hypothermia, thromboembolism. So in these cases also, the hypoxic pulmonary vasoconstriction mechanism can be inhibited. Drugs like vasoconstrictors giving a high FiO2, giving PEEP, also play an important role in inhibiting the hypoxic pulmonary vasoconstriction. Now, what potentiates hypoxic pulmonary vasoconstriction? So, a respiratory stimulant called almetrin and the prostaglandin inhibitors do play an important role in potentiating hypoxic pulmonary vasoconstriction, as has been shown in various models. Another important part that plays an important role in the hypoxic pulmonary vasoconstriction is the role of the cardiac output. So studies have shown that any increase or any decrease in cardiac output, it can decrease the mixed venous oxygen saturation when there's a fall in cardiac output, and it can increase the shunt fraction when there's an increase in the cardiac output. So both of these phenomena are detrimental to the adequate maintenance of the hypoxic pulmonary vasoconstriction. So maintenance of cardiac output is an important step while trying to manage the oxygenation and carbon dioxide elimination of the patient when he's undergoing one lung ventilation. So factors that affect the cardiac output also play an important role, like hypovolemia, use of certain instruments which can compress the heart or the great vessels, and thoracic epidural sympathetic blockade. Now, we'll come to the pre-anesthetic evaluation as to once the patient has come for a lung resection surgery, how do we go about? Being experts in pre-anesthetic evaluation, since we have been doing this since the first year of our post-graduation, so detailed history, taking the list of allergies, looking at the airway anatomy, evaluation of the cardiovascular system are the routine things that we see. In addition to this, there's a high importance or emphasis is given on the pulmonary function testing and evaluation of the patient for the lung resectability. So in the pulmonary function testing part, so I'll just tell in brief, now we have the level 1 testing, level 2 and the level 3 testing, which the patient undergoes when he's about to come for a thoracic surgery. So level 1 includes that of respiratory mechanics and the lung parenchymal function. In level 2, we do the low technology cardiopulmonary reserve assessment, whereas in level 3, we do the high technology cardiopulmonary exercise testing for that of the patients. In addition to this, a detailed cardiovascular system examination, renal and hepatobiliary system examination is also of utmost importance. Coming to the history, the MET scoring of the patient, if he's having any history of infection, any history of exposure of smoking, asbestos, radiation, history of lung cancer, or any history of kidney disease is very important. It has to be taken to be noted. And the patient has to be optimized before he presents to us before the surgery. When it comes to the lung cancer, the 4 M's are very important. That is a mass effect of the lung cancer itself, which can cause obstructive symptoms. Metabolic effects as seen in Lambert-Eaton syndrome in small lung cell carcinoma, metastasis, and effect of any antimitotic medications that the patient might be taking. Next, looking at the physical examination. So we have to do a detailed and thorough examination of the patient to evaluate him for his upper airway anatomy, as well as for planning of post-operative analgesia. So we look at the tracheal position, the chest wall abnormalities, auscultation of the patient is done. The various routine investigations are done for the patient, but with special emphasis on the cardiac, the renal, and the liver function test. Cardiovascular recommendations before lung resection surgery, it has been mandated that at least a pre-operative ECG should be taken for this patient. But if the patient is a high-risk cardiac patient or he has had some form of ischemic heart disease or valvular heart disease, he should undergo a thorough pre-operative cardiac evaluation. Now, why this is important is that right ventricular dysfunction is very much present and the patients can present with right heart failure, and this can happen even following the surgery. So we have to optimize this patient. So if we summarize the initial pre-anesthetic assessment for all patients, assess their functional capacity, advise them to discontinue smoking for at least 4 to 8 weeks. Cancer patients look at the 4 M's, and in COPD patients, the arterial blood gas analysis. And when it comes to the patients who have some form of kidney disease, increased renal risk has to be taken into account, so that in accordance to this, we will optimize and decrease the use of renal toxic substances in the anesthesia plan. Now, like I said, the pulmonary function test. So this is where we have to diversify and we have to evaluate the patient completely. So the level 1 pulmonary function test includes the FEV1 and the diffusion capacity of carbon monoxide across the lungs. In level 2, we have the stair climbing test and the shuttle walk test. And in level 3, we have the ergonomically bicycle design cardiopulmonary exercise testing. So what are the goals of a pulmonary function test is to find and identify the patients who are at increased risk. And if we can do something to reduce the risk, so as to decrease the morbidity and the mortality of the patient, and to look at the beneficial effects and reversibility of the airway disease. So in the respiratory mechanics, we have the post-expiratory volume, which is measured at 1 second. We calculate the predicted post-operative values. And in the cardiopulmonary, and then we have the DLCO test, which is again, we calculate the predicted post-operative values. So various studies over the years have shown that any of these FEV1 or DLCO, if it is more than 30 to 40%, then the patient is safe. But any value less than 30 to 40%, it is considered as unsafe and the patient is a high risk for surgery. So FEV1 itself is an independent predictor of respiratory morbidity. Along with this, in the spirometric exercises, we also look at the patient's vital capacity, the residual volume, and the maximum voluntary ventilation. Based on these studies, based on these parameters, we can divide the patient into the mild COPD, moderate COPD, and find out the patients who are at moderate to severe risk for undergoing the surgery. Now, there is no FEV1 prohibitive limit for anesthesia, but yes, it is there when it comes to surgery. The American Chest Physician Association has in 2013 emphasized that when we look at FEV1, we should look them at as a percentage of the predicted postoperative value over the absolute values. So how do we look at this predicted postoperative value? So there was various equations where we calculate the patient's preoperative FEV1 and then multiply it with the 1 minus functional lung tissue removed per 100. So according to this, we classify the patient into moderate risk and high risk. If it is high risk, if it's less than 30%. Now this changes for a patient who has coming for an emphysema lung reduction surgery versus a patient who has a lung cancer and is coming for surgery. So based on this, when we divide the patient's lung into the various bronchopulmonary segments, we divide them. So when it comes to right lower lobectomy, for a patient who's having the right lower lobectomy, for a lung cancer. So when we put this into the equation, it comes to that the patients, if he started with an FEV1 of 70%, he drops down to an FEV1 of 50%. Now coming to the lung parenchymal function. So like I have said, the diffusion capacity of carbon monoxide across the alveolar capillary membrane correlates to the total functioning area of the lung. So this is again an independent value. It is independent of the FEV1 values and therefore it has to be calculated. In including this also, we have to look at the patient's ABG, where we look at the PaCO2. Anything the value more than 45 millimeters of mercury puts the patient in the moderate to high risk category. So the previous guidelines, we were looking that the patient who is a low risk for surgery, the post-operative predictive FEV1 and DLCO should be more than 80%. But in 2013, these guidelines were revised, and anything more than 60% for the patient is considered as to be low risk for the surgery. Now, level 2 test. So in level 2 test, we look at the cardiopulmonary reserve assessment. So previously 6-minute walk test was done, but the 6-minute walk test has found to be having very less sensitivity and specificity. So we do the gold standard, that is the stair climbing test. It's a first line functional screening. And the patient, we ask them to that if they're able to do at least climb 2 flights of stairs, that shows that their maximum oxygen consumption without undergoing any dyspnea or having any symptoms is at least more than 15 to 20 ml per kg per minute. Or else we can also make the patient do the shuttle walk test, where he walks back and forth across 2 shuttle space and we gradually increase their speed. So if the patient is unable to complete 250 meters or at least 25 shuttles, then his maximum oxygen consumption is taken to be less than 10 ml per kg per minute, and he comes into the high risk category. So high risk is the oxygen consumption capacity is less than 15 ml per kg per minute, and a patient who's at low risk will have a maximum oxygen consumption of more than 20 ml per kg per minute. So this is the gold standard. So what about the patients who are at a high risk for cardiac surgery, who have a high cardiac risk factors and who fail this the level 2 tests also? So for these patients and for patients in whom an FEV1 has come to be less than 30%, we directly shift them to the Cardiopulmonary exercise testing, which provides us a global integrated assessment of the cardiovascular and the respiratory physiology. So in this test, it's a completely computer generated tables where we get the maximum aerobic capacity, the anaerobic threshold among the various other parameters, which also gives us the cardiac indices. So this algorithm presents all that I've discussed now before as a required pulmonary assessment for the pulmonary resection surgery. So level 1 test, if the patient is having a post-operative predictive value of more than 60%, he goes into a low-risk surgery, low-risk classification. Anything between 30 to 60% of FEV1 and DLCO, we make him undergo the level 2 stair climbing test. If he fails to complete the level 2 test, he goes for the level 3 CPET tests. Any patients who is having a high cardiac risk, he goes directly into the level 3 testing. And for high-risk patients, it's always better to give them palliative care and look for non-operative treatment. Now, in some centers, split lung function tests are also done, which helps us to look at the regional perfusion and ventilation before we make the patient undergo surgery using radioactive xenon. Now coming to the assessment of risk of surgery. So various risk indices have been advocated, out of which Thoraco score is currently the largest and most validated global risk score, which takes into account 9 variables and gives the risk score of the patient who is coming for surgery. To summarize, this table presents the physiology part that we have discussed of the ventilation perfusion relationship in the lateral decubitus position, and the preoperative assessment summarizing them. Important points or take-home points are that to estimate the predictive postoperative FEV1 and the DLC of the patient. If the patient fails them, go to the level 2, the stair climbing test. If the patient fails that also, go to directly the CPET tests. In cancer patients, we have to keep in mind the 4 M's. And in COPD patients, we have to divide them based on their bronchodilator. If they are responsive to bronchodilator, looking at the spirometric classification, we can classify them. And the most important part, which we also should do during the pre-anesthetic assessment, is to discuss the post-operative analgesia and the quality of life that the patient will be having following the surgery. So thank you so much for your patient hearing and kind attention. These are my references. Thank you, sir.
Yeah, thank you, Ananya, for your comprehensive presentation. And so far, we have discussed about physiological changes that are associated with one lung ventilation and lateral position, which is very common for most of these lung resection surgeries. After that, we have seen how to assess the patient, who are at risk, who are at less risk, who are more risk during desaturation, during surgery for desaturation or post-operative respiratory complications like infection or respiratory failure. And 2 important things what we learned so far is the calculation of post-operative predictive values of FEV1 and DLCO. As she told, we have 2 things. One is we need to assess both airways, that is called respiratory mechanics, air mechanics. Second thing is parenchyma, that is alveolar capillary membrane and alveolar and capillary membrane interaction, and which is basically essential for gas exchange. And third thing, what she told was cardiopulmonary interaction or cardiopulmonary reserve. So regarding this spirometry, what basically we look at only the respiratory mechanism, that is like alveoli, how much, sorry, airways. So airways anatomy and pathology will be assessed through only the spirometry. Whereas if you want to assess the parenchymal function, we have to do either ABG or else like DLCO, that is a diffusion capacity of lungs for carbon monoxide, which maybe most of the centers it may not be available, but still ABG can give most of the information. After that, if there is any problem with this test, then we go ahead with the level 2 or level 3, which basically involves cardiopulmonary interaction or assessment of the cardiopulmonary reserve. This is simple 6 minutes walk test or a shuttle walk test or a staircase climbing. We can assess the VO to max of these patients. Patients who is having more than 20 ml per kg per minute of VO to max, usually safer surgeries. Whereas less than 15% of 15 liters of VO to max will usually 15 ml per kg per minute of VO to max will have high risk for postoperative complications, and less than 10 ml of oxygen VO to max are very high risk for developing either during surgery desaturation or postoperative respiratory complications. Same thing is applicable for the FEV1 DLCO. But however, whenever you calculate FEV1 or postoperative predictive FEV1, we always make sure that the 1 minus functional lung segment that is going to remove. That means if in case of a destroyed lung, you may be removing entire right lung. Suppose a patient coming for right side destroyed lung, either tuberculosis or bronchiectasis, and you are planning for pneumonectomy. And usually this kind of patient will have compensatory changes on the left side. So in that scenarios, what we are going to remove is all non-functional lung tissue. That means whatever patient is having preoperative predictive FEV1 will be same even during postoperative period also, as we are removing only the destroyed lung. We are not taking out the normal lung. So these patients are relatively less chances of getting postoperative complications, or unless there is surgery related like hemorrhage, those things. From anesthesia, they are relatively safer for us. Unlike bilateral lung disease patient or patient with normal lung tissue. So normal patient, yes, if you are trying to remove the right lobectomy, almost all their FEV1 may be predictive postoperative FEV1 may be reduced to 30 to 45% may be reduced. That's the reason patient with normal lung or patient with supine surgeries are more prone for intraoperative desaturation. So any questions from the audience we can discuss right now in this topic, like pre-anesthetic assessment and lung physiology. Any doubts? Either you can chat or you can unmute yourself and you can talk. I also welcome Gopinath sir for blessing this this webinar. Sir, can I have any inputs from you, sir?
Hello.
Yes, sir. Good evening, sir.
Good evening, Sam. Nice talk by Dr. Ananya, and you have summed it up very well. So it's only when you have bilateral disease, lung disease, that generally we have significant problems in terms of perioperative management and hypoxia and things like that. I'm sure Dr. Sandeep will talk about it, but it's very important during preoperative assessment that you look at the dependent lung or the non-surgical resected lung also in terms of infective pathology. Normally, if you have, say, isolated mass or isolated segment, or if it's coming for lung volume reduction or, so just segmentectomies or lobectomies isolated, they generally do well. But if they have bilateral disease, then you have to really work up these patients properly. So I think once, I'm sure Dr. Sandeep will talk about all that, but very nice presentation, and you have summed it up very well. Thank you.
Thank you, sir. Good evening, Padma ma'am. Can I have some inputs from you, ma'am?
Yeah, as said, I think a very well presented thing. Ananya, congratulations. I don't think I have much to add to what Ananya has already presented.
Thank you, ma'am. Anyone interested to add, or anyone having doubts? So far, you can ask right now only. Later, we'll ask Dr. Sandeep will be presenting how to manage these patients during surgery. What are the practical issues when the desaturation develops during surgery or postoperative period? There are no doubts. We can ask Sandeep to present the topic. Sandeep, kindly share your PPT, Sandeep.
Yes, sir. Visible, sir?
Yes, visible. I think, yeah, visible.
Good evening, one and all.
Shyam, just a minute. Shyam, can you introduce Dr. Sandeep?
Yeah, Sandeep is my student when he was doing his post-graduation from NIMS, Nizam Institute of Medical Sciences, Hyderabad. After that, he has done DM Cardiothoracic Anesthesiology from Sri Chitra Institute of Medical Sciences, Kochi. And now recently he joined back as a assistant professor to in All India Institute of Medical Sciences, BP Nagar. Almost since 1.5 years he is working with us. So I request Sandeep to share his experience and other related things related to this topic.
Thank you, sir. Good evening, one and all. At the outset, it's an honor and privilege to be here today, and I thank everybody who is responsible for this. So today we'll be discussing on the anesthetic management of one lung ventilation. And sorry, it's not changing. Yeah. I'll be restricting my talk to the methods of one lung ventilation. How do you troubleshoot when you're having difficulty with one lung ventilation? A small note on pulmonary vascular resistance and hypoxic pulmonary vasoconstriction, and finally we'll end up with hypoxemia. So first, if you see what is the indication for lung isolation, it could be either to protect the lung from soiling, because in a patient having pulmonary hemorrhage or any purulent secretion, so that the opposite lung is saved from it. One lung ventilation is also used when you need to facilitate certain surgeries of the cardiac, thoracic, orthopedic, esophageal surgeries. And also certain situations need a differential pattern of ventilation, such as those patients undergoing lung transplantation and they have a reperfusion injury, or those with bronchopleural fistula. You need to differentially ventilate each lung. So these are usually the general indications for lung isolation. So coming to the methods of lung isolation, it's broadly divided into three things. Either you use a double lumen tube, a bronchial blocker, or a single lumen tube, or an endobronchial blocker. And the most common of these is the double lumen tube. So before that, I would just like to brief you on the anatomy of the tracheobronchial tree. If you see, the trachea actually bifurcates into at the carina into the right and left bronchus. The left bronchus is much longer. It's approximately 5 centimeters in length, whereas the right bronchus is very short. The right main bronchus, only 2 to 2.5 centimeters. So any device which you're using, be it a double lumen tube or a bronchial blocker, can easily fit over here, and the margin of safety is quite high if you're putting it on the left side. Whereas on the right side, your margin of safety is going to be low. So most of the time, we are going to prefer using a left-sided devices. Okay. With this, I'll come to the first device, that is a double lumen tube. The discovery of this was a landmark in the development of thoracic anesthesia because it allowed the anesthetist to obtain reliable lung isolation by just using the bronchial blocker can easily fit the margin of safety is quite high if you're putting it on the left side. Yeah. So if you see what is a double lumen tube, it is essentially just tubes which are connected side by side. One is the tracheal lumen or the tracheal tube, which is the shorter one and which is stationed, which is intended to be in the trachea, and it has a cuff which has a high volume and a low pressure cuff. And the second tube is the bronchial tube, which is a longer one, which is intended to be into the bronchus, the right or the left. This has a small volume and a high pressure cuff. The cuff, the pilot balloon, as well as the proximal portion of the tubes are all color coded, with white indicating for the tracheal side and the blue indicating for the bronchial side. Yeah. So the double lumen tubes are labeled either left or right, depending upon the side they're intended to be placed. We have all seen mainly the left-sided double tube. The right-sided double lumen tube has a small difference. It has a cuff which is not spherical. It is more or less like a sausage shaped, and the tip also has an opening for ventilating the right upper lobe bronchus. Now, how to select the size of a DLT? Mainly in adult females, we'll be using either the 35 size or a 37 French size. And in adult male, we'll be using 39 or 41 based on their height. Also, in places where we have a packed system and we can measure the tracheal width, this is actually more useful. So by measuring the tracheal width, you can actually guess what is the double lumen tube size you want to use. So a tracheal width of 14 approximately corresponds to a double lumen tube of 35, so on. And if you are having a tracheal width of more than 18, you can use a 41 French double lumen tube size. After selecting the size, we need to decide what is the depth of insertion. So in general, a 170 centimeters height person, you're going to insert it to a depth of 29 centimeters. And for every 10 centimeters change in the height, you're going to change the depth by 1 centimeter. A simple formula is depth of insertion is height in centimeters divided by 10 plus 12. All these well said and done, they're arbitrary and they need to be confirmed by auscultation or fiber optic bronchoscope after you insert this. So once we have seen what is a double lumen tube, what is the size we are going to select and how deep we are going to insert it, we need to see what is the method of insertion of DLT. So first we perform a direct laryngoscopy, see that the bronchial lumen of the double lumen tube is facing up, enter the glottis, and after entering the glottis, we actually remove the stillet. And after that, we can use two methods, whether you go blind or you use a fiber optic bronchoscope. If you're going blind, after removing the stillet, turn the double lumen tube either to the right or left, whichever side you want to send it to, and then advance it to the predetermined length, or until you get a resistance. Okay. And then the second method is that once you have crossed the glottis, then you actually insert a fiber optic bronchoscope through the bronchial lumen into the desired bronchus. And once you have inserted that, you thread the double lumen tube into the desired bronchus. So once this is done, then you actually inflate both the cuffs and you come for checking the position. So first method is you're going to check by auscultation. So in auscultation, when you have both the lumens open, you should be able to hear bilateral air entry. First, we occlude the tracheal lumen, and we are assuming that we have put a left-sided double lumen tube. We first occlude the tracheal lumen. That time we should be able to hear only breath sounds on the left side, whereas nothing on the right side. And then when you release it, there should be resumption of the bilateral air entry. And then we block the bronchial lumen, and then we should be able to hear breath sounds only on the right side. So with this, we have seen that by just using a single double lumen tube, you have the option of either ventilating the right lung or the left lung. So for any type of, whether you are operating on the right or the left lung, you can always use a left-sided double lumen tube. As I said, auscultation alone is unreliable for confirmation of a proper DLT placement. We also need to check the position using a fiber optic bronchoscope. So there are 3 steps how we are going to check using a fiber optic bronchoscope. So first thing is that after insertion of the double lumen tube, you're going to send the fiber optic bronchoscope through the tracheal lumen. And once you have just crossed the tracheal tube, you need to have a vision something like this, which shows that you're well above the carina. And also you should be able to see that the bronchial tube is entering into the bronchus, and the cuff of this, which is a blue color, you should be able to see it approximately 5 millimeters below the tracheal carina, and it should not be just at the carina, that it does not herniate into the opposite side. So with this, we have confirmed that it is, yes, it is the tracheal tube is in the trachea, the bronchial tube is well within the bronchus. But then the question arises, whether this... Yeah, then the question arises whether this bronchial tube has gone into the right side or it has gone into the left side. So to confirm whether this left-sided DLT has gone into the left side, or this could be the right side or this could be the right side. Okay, so for this, what do? We advance the fiber optic bronchoscope further into the right upper lobe bronchus. And then we should see something like this structure. If you're finding 3 orifice opening, that means it is the right upper lobe bronchus. This is the only structure in the entire tracheobronchial tree which has 3 openings. The entire other rest of the tracheobronchial tree has only 2 tube openings. Okay, so the moment you see this, we know that this is the right upper bronchus. That means we are in this is the right trachea, right bronchus, and this tube has gone into the left bronchus. So with this, we have confirmed that the tracheal lumen is in the trachea, the bronchial lumen is in the bronchus, and also the left-sided tube is on the left side. Yeah. Next, we remove the fiber optic bronchoscope from here and insert it into the endobronchial lumen. While inserting, you need to check the patency so that you have a good margin of safety, and then you need to insert the bronchoscope beyond the bronchial lumen. And then you should be able to see the orifice of both the left upper and the left lower lobes. which means that this tube is not too much down or not too much avoiding any distal impaction of the left apparent lower lobes. Yeah. So auscultation as well as bronchoscopy should be done each and every time a DLT is placed, and again when the patient is repositioned as well. So now let us look into a situation wherein you're having when you're doing a fiber optic bronchoscopy through the tracheal lumen, you see something like this. This is the bronchial cuff which is present at the carina. So what is it? It means that the tube is very much up. So we need to advance the tube further so that we can correct this mistake. The next situation, if you're after coming out of the tracheal lumen, if you find something like this, so this is the carina, and you're able to look at one bronchus properly, but the other one is not seen. So this usually signifies that you're too much inside. That is, the tracheal lumen is very close to the carina, and so here we need to withdraw the tube. Yeah. So this fiber optic bronchoscope actually helps us in exactly locating where the DLT is. A few words on the right-sided double lumen tube. The insertion method is same. That is, after crossing the glottis, you either you shift it to the right side and then advance it further. When you're checking with a fiber optic bronchoscope, first, as I said, you will be inserting through the tracheal lumen, checking that it is above the carina and the right bronchial lumen is into the right side. And then when we enter into the endobronchial lumen, we first see that it is not impacting very distally. And also another thing that we need to see on the right side is that you need to steer the bronchoscope through this opening, and you should be able to see this 3 orifice opening. So this shows that it is on the right side, and also this orifice is facing onto the right upper lobe bronchus. So with this, we understand that actually when you want to position a right-sided double lumen tube, it's going to be difficult because you need to take care of 2 dimensions. One is the depth has to be correct, and second is the direction or the orientation of the ventilating port should also be in such a way that it is directed to the right upper lobe bronchus. So, so actually, it is very difficult to use to properly position a right-sided double lumen tube, and so generally we use a left-sided double lumen tube whenever possible. However, there are certain situations where we have to use a right-sided double lumen tube. Suppose you're having a distorted anatomy of the entrance of the left main bronchus due to extraluminal or intraluminal compression, or there is any descending thoracic aortic aneurysm which is compressing this, we'll not be able to put a DLT on the side. Also, if you're going to do any surgery on this part of the bronchus, that is the left main stem bronchus, be it a left lung transplant or a tracheobronchial disruption, we'll not be able to use this side. And so we have to use a right-sided double lumen tube. Okay. Now let us see certain situations that we may face while you are using a left-sided double lumen tube. So think that we have put a left-sided double lumen tube, and then when you're auscultating, we are going to clamp on the right side or the tracheal lumen. And that time we find that we are able to hear breath sounds only on the left, which indicates that the bronchial lumen is on the left and it is as intended. That's the left-sided tube. The endobronchial lumen is on the left side. Next, we will clamp the left side of the tracheal lumen. But now if you are finding that you are hardly able to hear any sound, or it's very faintly heard only on this side, then we just deflate the bronchial cuff. And when you are deflating the bronchial cuff, if you are able to hear more breath sounds on the left side, but very less on the right side. So what does all this indicate? It means that, yes, your left-sided DLT has gone into the left side, but it has gone too deep inside. So the remedy for that is that you need to pull it out. Let us come to the second situation. So same thing, you have put a left DLT, and then when you're clamping the tracheal lumen, you're able to hear both the right and the left side. That means that your endobronchial lumen is not in any of the bronchus, it is much above that. Then we are going to clamp on the endobronchial lumen, endobronchial side. And with that, if you're not going to hear any sound, because this cuff is inflated, if you're not going to hear any sound, you just deflate the cuff, and again you're going to hear bilateral sounds. This means that your DLT is very much up in the trachea, it has not gone into any of the bronchus. And then the third situation, if you're seeing, after inserting the DLT, first when you're blocking the tracheal lumen, if you're hearing breath sounds only on the right side, you put it left DLT, but you're hearing breath sounds on the right side. It means that your DLT has gone into the right bronchus. Next, if you're going to clamp on the left side. And then you're hearing that you hear no breath sounds, or you may hear faint sounds only on the left side. And then you deflate this balloon of the bronchial lumen, and then you start hearing breath sounds more on the right side. So this indicates that not only that you have inserted your left-sided DLT onto the right bronchus, but also it is too much deep inside. So you need to reposition it. So if you actually go in a systematic way, we find that there are only 3 or 4 situations where your double lumen tube can be placed. And so anesthesiologists, without panicking, must be familiar with these malpositions and find a solution and address them effectively and fast. So if you go, there are a lot of advantages of DLT. It is easy to place successfully. Even if you do not have a bronchoscope, you can actually place a DLT. However, it is recommended to have a fiber optic bronchoscope. And then we can alternate between any of the lung, either the right or the left, by just putting one lung. The main disadvantage of a DLT is that size selection is going to be difficult, and due to its sheer size, it's large. So there's always a potential for laryngeal and bronchial trauma. And in patients with difficult airway, it's a contraindication. You cannot use a double lumen tube. And if you want to ventilate the patient postoperatively, double lumen tube cannot be used. You need to change over to a single lumen tube. As said, complications, mainly the malpositioning, and we have seen how to deal with it. There could be a tracheal bronchial disruption. This mainly occurs because of inappropriate tube size. If you're using a too big size of the tube, you can have a disruption. Or if you're using a too small size of a tube also, there can be migration of the tube inside such that the tracheal lumen also comes into the bronchus, and this could lead to a tracheobronchial tree disruption. Now, let us move on to the second device, that is the bronchial blockers. So bronchial blockers are devices which are used to block either the main stem bronchus so that the lung distal to it collapses once you block this, or it can be used to also selectively block either of the lobes, either the right intermediary bronchus, or here you can use the left upper bronchus. You can use it to block either an entire side, or you can block only a lobe. And all bronchial blockers have a unique mechanism to assist placement, based on which they are divided. There are different types, but all the bronchial blockers require fiber optic guidance. So if you come to the first one, which is the ANT wire guided endobronchial blocker, this one has a tip which is made up of it has a nylon wire loop at the tip, and to this tip actually a bronchoscope is threaded, and after that the blocker and the bronchoscope are then threaded together. And under bronchoscopic guidance, we actually guide the blocker into the desired bronchus, and then withdraw the fiber optic bronchoscope, inflate the balloon, and see whether lung isolation is proper or not. The next one is the Cohen endobronchial blocker. This one, the mechanism is that this tip of the endobronchial blocker can be deflected. And how do we deflect this tip? The proximal point, we have a balloon over here. We have a wheel over here, and by turning the wheel, we can actually deflect it either to the right or the left. And under fiber optic bronchoscope guidance, we can actually direct it into the desired bronchus. The other one is the Fuji Uniblocker. In this has a malleable material, and you can actually, by using your hand itself, you can actually change the shape of it so that you can actually keep it into a desired shape so that it preferentially goes into a bronchus. And then under fiber optic bronchoscope, you actually guide it into the right or the left sided bronchus. Recently you introduced one is the EZ blocker. This one has a Y shape and has 2 bronchial blockers at the tip. Okay, this is one and this is the one. And under fiber optic guidance, this Y-shaped connection between the 2 blockers is seated at the carina. Okay, so if you see this picture, in this picture, under fiber optic guidance, the EZ blocker has been positioned into the carina. Okay, and we see that the yellow or the green right mainstem bronchus is in the right side, whereas the blue one is in the left bronchus. And once you have properly positioned it, we know that this is the right side because we're able to see the right upper lobe bronchus over here. Okay, so if you inflate it by just 7 ml, you're going to block only the right intermediary bronchus, whereas your right upper lobe bronchus is going to be spared. And then add another 7 ml to it, then the right lobe bronchus is going to be blocked. And then you can deflate it and inflate 10 ml onto the left side, and then you see that the entire left side bronchus is blocked. So by using a single bronchial blocker, you can actually use it for either blocking the right side or the left side. So it can be used when you're using a double lung, two-sided procedures. So these are the various advantages and disadvantages. The main advantage of a bronchial blocker is that it can be easily guided through a regular endotracheal tube, and it is easier in patients with difficult airway or in patients with tracheostomy. Biggest disadvantage is that it needs a fiber optic bronchoscope to place it in position, and there is a lot of malpositioning which can happen when you're using this actually. There are certain situations where you will be actually preferring a bronchial blocker. Those are previous patients who have a challenging airway or a difficult airway. And in patients who are cancer patients and who have had a previous pneumonectomy, these patients, you obviously cannot put a double lumen tube. The only option will be a bronchial blocker. So selectively do a lobar blockade in these patients. The other one is the endobronchial intubation with a single lumen tube. So in this, you can use a routine single lumen tube, or you can use actually an endobronchial tube, which is a longer one and which also has a balloon which is more at the tip and not away. It is the easiest one, especially in adults and children, if you want to put it in an emergency. If the patient is having a pulmonary hemorrhage or copious purulent material, this is the one which will be very easy to insert. Let us come to certain situations where you are having a difficult airway and you need to have a lung isolation. How are you going to do it? This is a simple algorithm. If you see, suppose a patient is having, you first clinically assess, and if the patient is having a difficult intubation, first you assess whether the bag mask ventilation is going to be easy or no. If it is an easy bag mask ventilation, you can actually anesthetize the patient and either put a double lumen tube or use a single lumen tube first. However, if it is going to be a difficult bag mask ventilation as well as difficult intubation, what you want to do is first an awake intubation using a single lumen tube. And once you have secured the airway, then you assess whether the patient needs a double lumen tube, it's necessary or it's preferred. If the answer is no, then you actually prefer using a bronchial blocker. But if the answer is that you want a double lumen tube, then better exchange a single lumen tube using an exchanger catheter. And first you have to do a video laryngoscopy guidance and then insert your exchange catheter and exchange a single lumen tube with a double lumen tube. We need to note that these exchange catheters are longer than the routine exchange catheters, and they should be at least 83 centimeters long if you want, because to account for the longer size of the double lumen tube. Yeah, in patients with tracheostomy, what are the options? Either through the tracheostomy, insert a bronchial blocker under fiber optic guidance, or you remove the tracheostomy, put a single lumen tube and a fiber optic bronchoscopy. Or there is one DLT, which is known as the Norgate DLT. It is specially designed for patients with tracheostomy. It is very short and it can be used for patients who are having a tracheostomy in place. Now, if you come to the management of patients with one lung ventilation, the anesthesiologist has unique and actually conflicting goals when you want to manage these patients. Our goal in one lung ventilation is that you have to maximize the atelectasis or the collapse in the non-ventilated lung so that the surgical exposure is good. Whereas at the same time, in the ventilated lung or in the dependent lung, you have to avoid atelectasis and use that lung to the maximum capacity. So anesthesiologist has to do everything possible to achieve this. That is collapse on the operative lung and avoid any sort of collapse on the other side. So how do we go about it? So the first thing what we need to do is that how are we going to collapse the lung fast? So one thing which has been found is that the gas mixture which we are going to use in two lung ventilation actually influences how fast it is going to collapse once you start one lung ventilation. So if you are using an air oxygen mixture, the nitrogen which is present in this mixture delays the collapse because it is less soluble. So it is going to take a longer time to collapse. Whereas oxygen is more diffusible and it collapses faster. Actually, nitrous oxide collapses faster, but due to various reasons, we will not be using nitrous oxide in thoracic surgery. So we need to denitrogenate the patient and ventilate the patient with 100% oxygen for some time before starting one lung ventilation so that the speed of collapse of the non-ventilated lung is fast. The second thing we all know, the second goal of us is that we need to avoid any sort of collapse in the dependent lung or the ventilated lung. So how we go about this? Any patient with a two lung ventilation, we are going to have some amount of atelectasis. So this is normally in a normal patient, because both lungs are being ventilated, it can be compensated, no desaturation. However, in patients with one lung ventilation, you need to avoid any atelectasis. This we do by performing a recruitment maneuver. So how do we do this? We hold the lung at end inspiration for 20 centimeters of water for 15 to 20 seconds to see to it that the entire lung is inflated, and then we actually start the one lung ventilation. So with this, we have seen to a certain extent that we're having collapse of the non-ventilated lung and avoiding any collapse of the ventilated lung. The next what we need to do is that, if you see in a normal physiology, both the lungs are ventilated as well as both the lungs are being perfused. But when you start one lung ventilation, you're avoiding ventilation to an entire lung, whereas perfusion is still happening to this lung. So all this perfusion which is going to be shunted, and it is going to come out as desaturated blood. So your pathophysiology of one lung ventilation involves how you or the body's ability to redistribute this blood flow away from this lung to the ventilated lung. So as an anesthesiologist, you should use all your factors to divert blood away from the non-ventilated lung towards the ventilated lung. So how do we do about this? So if you see the pulmonary vascular resistance, when you increase the PVR, blood flow to that lung will be decreased. So using that, our goal during one lung ventilation is that we need to maximize the PVR in the non-ventilated lung and minimize PVR in the ventilated lung. See this graph, which is a lung volume versus pulmonary vascular resistance. We see that the lowest PVR is at the functional residual capacity. This means that we need to keep our ventilated lung at this lowest PVR, that is, keep it at the functional residual capacity. Whereas the non-ventilated lung, definitely we cannot go this side. We have to go on this side only. The non-ventilated lung, we need to keep it as collapsed as possible or as close as to the residual volume, so that we maximize the PVR and divert all the blood flow away from it. And then a small note on hypoxic pulmonary. A small note on hypoxic pulmonary vasoconstriction. Normally, when there is a decrease in the pulmonary, any decrease in the alveolar oxygen tension is going to cause pre-capillary vasoconstriction, and it will divert the blood away from this zone to the more ventilated lung. So by this method, actually, there is a decrease in the blood flow to the non-ventilated lung by almost 50%. So hypoxic pulmonary vasoconstriction is beneficial, and we need to promote this. And also we need to understand that hypoxic pulmonary vasoconstriction is a biphasic pattern. And and also the offset is also biphasic. This is important because if you're having a double lung procedure, the patient is going to be in a desaturation for a longer time because the offset of the HPV has not yet happened. So continuing, as anesthesiologists, we need to promote hypoxic pulmonary vasoconstriction and avoid anything which is going to decrease it. So vasodilators such as NTG, SNP, or high doses of volatile anesthetic or nitrous oxide, all of this inhibit hypoxic pulmonary vasoconstriction, and hence we need to avoid this. And then moving on to the ventilation strategies during one lung ventilation, there is no one formula which can fit all the patients. We need to tailor it to each patient. But however, we begin with a tidal volume of 5 to 6 ml per kg to maintain a peak airway pressure of less than 35 and maintain a plateau pressure of around 25 centimeters of water. Use a PEEP of 5 centimeters of water, but however, in patients with COPD or those patients with auto PEEP, we need to be careful with this. Your respiratory rate should be tailored to a CO2 of normal CO2. A little bit of permissive hypercapnia is allowed. Both volume and pressure control can be used, but pressure control is preferred for patients with bullae or in both post-lung transplant patients. And coming to the most dreaded complication or the major concern during one lung ventilation, which is hypoxemia. So a saturation of more than 90% is commonly accepted. However, in patients with coronary artery disease or in patients with anemia or decreased cardiopulmonary reserve, we need to target a higher saturation in these patients. We need to understand that hypoxemia during one lung ventilation is predictable, preventable, as well as treatable in vast majority of cases. So we need to predict patients who are going to hypoxemia so that we can direct our resources towards these patients and be ready for this. So how do we do it? See, if a patient has a preoperative ventilation perfusion scan, The patients who have a higher percentage of ventilation or perfusion to the operative lung or to the lung where you're going to use a one lung ventilation or you're going to deflate it, these are the patients who are going to desaturate faster. Also, patients who are having a low saturation with two lung ventilation, definitely they are the ones who will be desaturating with one lung ventilation. A right-sided procedure, because the right lung is larger and the perfusion to the right side is more. So a right-sided procedure, you're going to, these patients will desaturate. And patients in supine position of one lung ventilation also desaturate faster. And once you are having hypoxemia, how do we go about it? We first need to see whether it is severe or a sudden fall in saturation. If it is that, immediately resume two lung ventilation if it is possible. If it is a gradual desaturation, first you need to increase the FiO2 to 100% and then check the position of the DLT or the bronchial blocker using a fiber optic bronchoscope. Most commonly, this will be the cause for your desaturation. And then we need to optimize the cardiac output. If your cardiac output is low, your pulmonary blood flow will be low and you can desaturate. So optimize the cardiac output, promote hypoxic pulmonary vasoconstriction, decrease your MAC of the anesthetics. And then apply a recruitment maneuver to the ventilated lung. Apply PEEP to the ventilated lung, approximately 5 centimeters of water if there is no contraindication. And then you need to apply CPAP to the of 1 to 2 centimeters to the non-ventilated lung. This is actually a device which is used and it has a valve wherein you can actually titrate how much of CPAP you want to give it to the non-ventilated lung. So here we attach oxygen to this and then titrate how much PEEP you're going to give to the non-ventilated lung. Basically, this is so that any shunted blood is also getting oxygenated. And then we can also use partial ventilation methods when you're having a severe hypoxia. How do we do this? So first method is that intermittent positive airway pressure to the non-ventilated lung. So if you're having a double Lumen tube, so you attach a standard bacteriostatic filter to this non-ventilated lumen of the DLT and attach to the CO2 port oxygen with 2 liters of oxygen. And intermittently, you keep closing this and opening it. When you close it, you're actually sending oxygen into this and it is intermittently inflating it with the oxygen and there is some amount of improvement with oxygenation in this method. The next method is selective insufflation of oxygen to recruit lung segments which are on the side of surgery but remote from the site of surgery. So what do I mean by it? So if your right lung is actually, if you're doing a surgery on the left side of the lung but you're desaturating, so what you do? Use a fiber optic bronchoscope and go into the bronchus which is away from the site of the surgery, okay? And then you connect oxygen through the suction port of this fiber optic bronchoscope and start it at 5 liters per minute of oxygen and keep using the suction port. And with this, we are actually insufflating oxygen on the side of the surgery, but which is remote from the site of the surgery. The third method, if you're not able to ventilate with this, we go for selective lobar collapse. That is, instead of collapsing the entire lung, we actually either collapse the intermediate bronchus or on the left side, the left upper or the left lobar bronchus. If all these methods fail, what we can do is mechanical restriction of pulmonary blood flow. So we see that, as I said, we need to restrict the pulmonary blood flow to the non-ventilated lung. So we can ask the surgeon to restrict the pulmonary blood flow by applying clamps onto this pulmonary artery so that we can restrict the pulmonary blood flow. If you have a pulmonary artery catheter in place, inflating it can actually restrict the pulmonary blood flow onto that side temporarily. So in summary, I would like to say that whichever method of lung isolation you're going to use, the ABC of lung isolation or for any thoracic surgeries, first A is anatomy. Know the tracheobronchial anatomy. One of the major problems that many anesthesiologists have in achieving satisfactory lung isolation is lack of familiarity with the distal airway anatomy. All of us know about the proximal airway up to the glottis, that is the epiglottis, and also the vocal cords. But beyond that, we actually are not really familiar. So familiarizing with the anatomy is very important. Second thing is bronchoscopy. It's a fundamental skill needed by all anesthesiologists who are providing for thoracic surgery. So whenever possible, always use a fiber optic bronchoscope to position either a bronchial DLT or a bronchial blocker. And the third one is chest imaging. Always consult the chest imaging before placement of a double lumen tube or broncher. Any abnormalities which you're seeing on this imaging can be identified in advance, and this will aid in selection of the optimal method of lung isolation. So if we are sound with this knowledge, we can actually plan well in advance and avoid any mishaps, and we can deal with it well in advance. Thank you.
Thank you, Dr. Sandeep, for your excellent presentation. Even though it is 35 to 40 minutes presentation, it's very nice. And coming back to some of the practical application of this talk. This talk basically contains 2 points. One is how to anticipate difficulty in isolation of the lungs. Whenever you plan for one lung ventilation, sometimes we need to anticipate which patient is going to difficult to isolate, and selection of the various 3 methods, whatever Sandeep has been told so far. So always look at the X-ray or CT scan films. Don't just read the report. And most of the times I have seen, whenever I receive the pre-anesthetic over from my junior colleagues, they never see the CT scans or X-rays. Make a habit that you should observe what is the compression or what is the deviation of trachea, whether you can place double lumen tube, or you need to directly go for a bronchial blocker or other methods. So in your place, wherever you are working, the availability of the sizes, various sizes. Based on this, we need to assess before surgery, because on the day of the surgery, you may not get different kinds of size by ordering just 1 or half an hour before the surgery. So make sure that see the all chest X-ray and other radiological investigations, and plan for what are the size as well as type of the device. Second thing, as Dr. Sandeep mentioned, the sizes what he has mentioned is for Western people, whereas for Indians, most of the time for us lung surgery is either destroy lung because of tuberculosis or maybe bronchiectasis. This is basically poor man disease, because of this reason, most of the patient may have short stature. So go for females, go for 28 and 32, or for adults, males 34 or 35 or 37. Next, depth. Like again, the depth, whatever described means height by 10 plus 12, or else you just advance the tracheal tube until you get resistance. Once you got resistance, stop there and auscultate. And based on the auscultation, you decide whether you need to pull or push in. Fourth thing is which cuff need to be inflated, whether tracheal cuff or bronchial cuff. These are the questions commonly asked in the examination also. So most of the times when you don't want to, like a patient with isolation is required for intrabronchial hemorrhage or to avoid spillage of infectious contents to the normal lung, then in that scenario, it's better to include bronchial cuff first, then tracheal cuff. In other situations, it doesn't matter whatever cuff you inflate. And one more thing is fiber optic bronchoscopy. Even though it's a very important tool, it may not be mandatory for most of the situations. So last 15 years, I might have used maybe once or twice. We never had a problem of not having fiber optic bronchoscopy. But again, yes, it's important to have fiber optic bronchoscopy. Then regarding bronchial blockers, I have used easy bronchial blockers, which may not be requiring fiber optic bronchoscope. So you can just blindly insert, and by auscultation, you can position and reposition these blockers. And however, during middle of the surgery, once it is displaced, again, it's not easy to place it back in position. This is the first part of difficulty in isolation, or what are the various methods for isolation in this one lung ventilation. Then the second thing is desaturation. So whenever there is intraoperative desaturation, auscultation is one thing which always bail out from the situation. Try to get a space either front of the chest or back of the chest to auscultate the upper both dependent lung and the non-dependent lung, and look for malposition of the double lumen tube, which is the common cause. Second thing is for development of pneumothorax, because there is most of the times disease is bilateral. When you use one lung ventilation, there is a bullae rupture is possible in the dependent lung, or else sometimes secretions can block the lung. So better if you just do suction, and the patient will improve. So this can be identified by added sound during auscultation. And regarding outcomes, the only 3 interventions that has been shown to increase the outcomes are cessation of smoking before surgery. Second thing, intensive respiratory physiotherapy. Third thing is thoracic epidural analgesia. Make sure that these 3 things are important for improving perioperative outcomes. With this, I invite senior faculty to give our inputs about this topic and also encourage the participant to ask questions. Sir Gopinath, sir, anything you want to add, sir?
Just a couple of points for the students when I think when we were training or when you are working with us, and before I left, fiber optic was not a big option because we had 2 of them, both of them, multiple uses in locations, they got spoiled. But that apart, whenever you have a bronchoscope, as soon as you enter, like Dr. Sandeep described, placement of tube by fiber optic and checking by fiber optic, which is the first way, even at least for the exam going student, that should be our first option of saying, yes, we will check by fiber optic. So as soon as you go down the tracheal lumen, what you see is referred to sometimes as the primary carina. So how do you identify? It is by the tracheal ring. So posteriorly, you will see ridges when you go through. So if you enter through the bronchial lumen to identify the left side of the lung, then you see again 2 openings like he described, except the right upper lobe, everything is 2 openings. But still you could be too far out and visualize the primary carina. So the secondary carina, as it is referred to, that is left lower and upper lobes, you do not have posterior ridges on the posterior wall. So that is how you identify the carina or the secondary carina or the left lung. So these are 2 small points the students can keep in mind. Next is, of course, it's always whenever you are using fiber optic, after positioning the patient in the surgical position required, you should again repeat a fiber optic bronchoscopic examination to ensure that the tube was not displaced during positioning. So these are some important things, and of course all the rest has been mentioned, and likewise from our physiology that you learned in the first lecture. FiO2 is always, when you give anesthesia, general anesthesia, it is 30 to 33%, 0.33 or 3.3% FiO2 you always maintain for regular GA. When you come to one lung ventilation or thoracic, unless there is, like I said in the beginning, the lung is relatively normal when you have an isolated nodule for a lobectomy or a segmentectomy, FiO2 should always be 0.5. So your starting FiO2 should be 0.5 to take care of all the shunt or VQ shunt or mismatch which has taken place till the HPV sets in, because you have realized that there is 2 biphasic. First is quick, second is later. Again, as soon as you have positioned or started one lung ventilation, if you do not see any drop in saturations, don't vanish from the OT. It takes about 10 or 15 minutes before desaturation begins for all, then physiological changes take place and HPV kicks in. So HPV desaturation will not manifest immediately. So it might take a good 15-20 minutes. So you should always be present till the first half hour at least of one lung ventilation being established. So this is only practical points and safety wise to ensure that you do not have a mishap. And all the rest of the things like Dr. Sandeep discussed are the optimal ways of managing patients, especially if you have difficult airways. So you should know how to isolate lungs. So I think all of them are valid points. So one of the older ones which we used to use when we did not have blockers was a Fogarty balloon and a PA catheter itself with the balloon inflated. So these are some anecdotal ones. Thank you.
I request Dr. Nagarajan sir, any pediatric ways of doing lung isolation? Dr. Nagarajan is a pediatric cardiac anesthetist from KIMS Hospital.
Yeah, Sham, thank you, Sham. That was a very nice talk. But personally, I would say that, yeah, I was just learning from the talks, not much experience on the pediatric single, and frankly, not many things which are available. I've been thinking that if we have to go in, probably we would still have to use, as Gopinath sir told, some Fogarty or a PA catheter, or a PA catheter only to exclude the, for a single lung ventilation. Without that, I think as of now, not many things seem to be available for good single lung ventilation in pediatrics.
Most of the pediatrics are young patients, maybe endobronchial intubation is most of the time sufficient to manage one lung ventilation.
Yeah.
Padna ma'am or Srilata ma'am, can you add some inputs, ma'am?
Yeah, congratulations, Sandeep, on a very nice presentation. There's one thing that I want to add is the indications for double tube placement and one lung ventilation are expanding. So more and more surgeries are now being done in supine position. So traditionally, when we talk about one lung ventilation, we always think of lateral decubitus position. But the physiology in a supine or prone position is different, and the hypoxemia is more severe. And also, like when we look at expanded indications for the one lung ventilation, they're most often in lungs which are normal. So the hypoxemia is more severe than what is predicted by the traditional formula with FEV1. If you look at the prediction for hypoxemia, probably the formula with FEV1 is not very accurate in predicting the drop of hypoxemia. If you have one, probably DLCO2 will be a better way of predicting. And sometimes you can use the gradient between the end-tidal and the PaCO2 as a predictor for drop in the oxygen after you isolate the lungs.
Thank you, ma'am. Any other comments or queries? Then I request Dr. Ramakrishna sir to conclude the session.
Yeah. Good evening. I'm Dr. Veeresham, President of ISA Telangana. Thank you for the
good evening, sir. Good evening, sir.
Very good moderation and the nice presentation of both the speakers. Actually, we learned a lot by listening to this webinar. What to be done, even for postgraduates, it is highly useful. The practitioners, you see, we are not much practicing. Most of the anesthesiologists are not practicing, only super specialty places like institutes. They are doing a lot of cases, and it is much useful for everybody. Thank you very much, Dr. Nanda and Dr. Sandeep, and very good inputs from Dr. Gopi sir and other person like Padmaja Durga and Nagarajan. Thank you very much, Mananda. I think it is better to wind up for this. Thank you each and everybody for this contribution, sir. Thank you very much. Is it audible for everybody?
Yes, sir. Audible, sir.
Thank you, Dr. Shyam.
Yes, sir.
Thank you, Dr. Shyam, and all the speakers, Ananya and Sandeep. Very good program, excellent lectures, and very good discussion also. And participation wise also, we have almost 75 participants today, 46 in Zoom and others in YouTube. Thank you. Thank you, everyone.
Thank you, sir. With that, we conclude the session.
Shyam, sorry.
Yes, ma'am. Madam.
Yeah.
Congratulations, Sandeep and Shyam. Very nicely presented. I have only one thing to ask. Like initially, before we never used to do it for prone, but last 5-6 years we have started in prone. So I didn't had any problem with like hypoxemia or something. But I just want to ask, any experience like having hypoxemia after DLT placement from supine to prone? Anyone has faced like any experience wise?
Yeah, I think we were doing some of these thoracoscopic esophageal resections in prone position with the double lumen tube placement and lung isolation. And we felt that the drop in the oxygenation was greater in prone position than compared to the lateral decubitus position. So also in supine position, when you do a lung isolation, the hypoxemia is more severe than in the lateral decubitus position, obviously because we do not have the advantage of the gravity for the shift of the pulmonary blood flow into the dependent ventilated lung. So when you do not have a dependent ventilated lung and both lungs are in the same position, or the gravity doesn't help us in shifting the blood flow there. So we have to entirely depend on the HABR for, the HPV for the pulmonary blood flow shifting to the oxygenated lung.
Thank you, ma'am.
And ma'am, based on this, we understood that the best position for one lung ventilation is lateral position, or else followed by prone, followed by supine. Is that correct, ma'am? In terms of safety wise?
I would put, now when you have a hypoxemia in prone position, again, it's very difficult to look at the positioning or readjust the tube. So probably I would put decubitus, supine and prone.
Okay, ma'am. Sure. Thanks for that valuable inputs, ma'am.
Thank you, ma'am.
So thank you all for attending this webinar. And with that, we conclude the session.
Thank you very much, each and everybody. Thank you, sir.